Hello, I'm Dr. Roger Henderson and I co-host the GPnotebook study groups. Welcome to the GPnotebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. Now, in this episode, I'll be discussing oral mucosal cancer, and one of our listeners has asked if we could review this. I'm very happy to. And I'm referring here to malignancies arising from the mucosal lining of the oral cavity. So this includes the lips, buccal mucosa, gingiva, alveolar ridges, anterior two-thirds of the tongue, floor of the mouth, the hard palate, and the retromolar trigone. Now, from a clinical perspective, any precise anatomical localization isn't just academic. It directly influences staging, surgical planning, and prognosis. And one of the most important distinctions that we must make here as GPs is between the oral cavity and the oropharynx. These two regions are closely related anatomically, but differ significantly in tumour behaviour, risk factors, and treatment outcomes. The oral cavity is generally considered to extend up to the anterior tonsillar pillars, the junction between the anterior two-thirds and posterior one-third of the tongue, and the inferior border of the soft palate. And beyond these boundaries lies the oropharynx, including structures such as the tonsils and tongue base. Now, why does this matter clinically? Well, cancers of the oral cavity and oropharynx may share symptoms, but they differ in etiology, especially regarding viral associations, and so their treatment pathways can diverge significantly. Accurate anatomical identification therefore supports correct diagnosis and optimized treatment planning. So understanding the multifactorial etiology of oral mucosal cancer is crucial for prevention and early detection, and the dominant risk factors still remain tobacco and alcohol, particularly when used together. And their combined effect is not simply additive, but synergistic, meaning that the risk escalates far more with both than for either factor alone. So let's start with the big one, tobacco. Smoking introduces a range of carcinogenic compounds, including nitrosamines, benzopyrenes, and aromatic amines, all of which have well-documented mutagenic potential. And clinically, we often observe that long-term smokers have a markedly higher incidence of oral malignancies compared to non-smokers. And importantly, passive smoking shouldn't be overlooked here. Chronic second-hand exposure increases risk, especially in enclosed environments. Now, in many parts of the world, tobacco exposure isn't just limited to smoking. Smokeless forms, such as chewing tobacco, snuff, and betel liquid, play a significant role in carcinogenesis. Betel liquid, commonly used in parts of South Asia and the Pacific, involves prolonged mucosal contact with carcinogenic substances, which can significantly increase malignant transformation rates. Similarly, snus and other smokeless tobacco products, often placed under the lip for extended periods, maintain direct mucosal exposure and are strongly associated with oral cavity cancers. Alcohol's the other major contributor, and although ethanol itself isn't classified as a direct carcinogen, it increases mucosal permeability and facilitates the penetration of carcinogens into epithelial tissues. So from a clinical standpoint, patients who both smoke and consume alcohol represent a high-risk population and so warrant vigilant screening. Human papillomavirus, HPV, particularly types 16 and 18, is well established in oropharyngeal malignancies as increasingly being investigated in relation to oral cavity cancers. Now, while the association is less definitive compared to oropharyngeal disease, evidence does suggest a higher HPV prevalence in patients with oral squamous cell carcinoma than in individuals with normal mucosa, and transmission is most commonly linked to oral sexual contact. Another less frequently discussed but still clinically important risk group includes patients who've undergone hematopoietic stem cell transplantation or solid organ transplantation, because these individuals are immunosuppressed and may develop chronic graft versus host disease affecting the oral cavity, presenting with mucositis, xerostomia, and lichenoid changes. And over time, these chronic inflammatory alterations can predispose to malignant transformation, often several years after transplantation. Now, from an epidemiological perspective, oral cavity cancers account for a relatively small proportion of all cancers globally, roughly around 2% or so. However, their burden is unevenly distributed. Incidence rates are particularly high in South Asia and certain Pacific regions, largely due to widespread use of betel quid and smokeless tobacco. Gender differences are also notable because men are affected approximately twice as often as women, which likely reflects a higher exposure to traditional risk factors such as smoking and alcohol. Interestingly, while oropharyngeal cancers, particularly HPV positive ones, have shown a rising trend, the incidence of oral cavity cancers in some regions appears to be declining, possibly due to reduced smoking rates and improved public health awareness. Now, histologically, over 90% of oral cavity cancers are squamous cell cancers, and this is a key point because it influences both treatment and prognosis. And these malignancies often arise from pre-malignant lesions exhibiting epithelial dysplasia, most notably leukoplakia and erythroplakia. And while squamous cell carcinoma dominates, other malignancies can occur, including verrucous carcinoma, mucosal melanoma, Kaposi sarcoma and sarcomas in general, lymphomas, and rare intraosseous carcinomas. And although less common, these should all remain within the differential diagnosis when we're assessing atypical lesions. Now, clinically, oral mucosal cancer can present in a variety of ways depending on its location and stage, and early lesions are often subtle and may appear as persistent white patches, red patches, or mixed lesions that don't resolve, and they're often painless, which unfortunately can contribute to a delayed presentation. But as the disease progresses, these lesions tend to become indurated, nodular, and ulcerated, and patients may then report localized pain, bleeding, or just a non-healing ulcer. And location-specific symptoms can provide us with diagnostic clues. For example, tumours affecting the tongue may cause dysarthria or difficulty protruding the tongue, whilst lesions involving the alveolar ridge may result in loose teeth without any other obvious dental pathology. Now, advanced disease may present with dysphagia, odynophagia, referred otalgia, hoarseness, weight loss, or cervical lymphadenopathy. And these systemic and regional symptoms often indicate local invasion or metastases. So it should go without saying that a thorough clinical examination is absolutely essential here. And this should include a systematic inspection and palpation of the entire oral cavity using adequate lighting and tongue depressors, followed by a comprehensive neck examination to assess lymph node involvement. Flexible nasendoscopy is also valuable to exclude synchronous tumours in the oropharynx or larynx, which aren't uncommon in high-risk populations. But the cornerstone of diagnosis still remains biopsy, and any suspicious lesion that persists beyond 2 weeks, particularly in high-risk individuals, should be biopsied. And many lesions can now be sampled in an outpatient setting if accessible and well tolerated. But lesions in posterior or hard-to-get-to regions, such as the tongue base, may require examination under general anesthesia to obtain an adequate tissue sample. In cases where cervical lymphadenopathy is present, ultrasound-guided fine needle aspiration can aid in cytological assessment, and this is particularly useful for staging and treatment planning. Endoscopic evaluation in secondary care, especially pan-endoscopy under general anesthesia, allows for comprehensive assessment of the upper aerodigestive tract and facilitates the detection of synchronous primary tumours and helps to evaluate tumour mobility and depth of invasion. Imaging, as you know, does play a central role in staging, and contrast-enhanced CT scans are typically used to evaluate tumour extent, bone involvement, nodal disease, and any potential thoracic metastases. MRI scans are preferred when soft tissue delineation is critical or when iodinated contrast is contraindicated. PET scanning may sometimes be indicated in advanced disease or when the primary tumour site is unclear. Now, staging, as usual, is based on the TNM classification system, incorporating tumour size, nodal involvement, and distant metastases. An important addition in modern staging is the depth of invasion, which has significant prognostic implications in oral cavity cancers. Small tumours with limited depth of invasion are classified as early stage disease, whereas larger tumours or those invading adjacent structures, such as cortical bone or skin, are considered advanced. Nodal staging is equally critical, as lymph node involvement significantly worsens prognosis, and the presence of extranodal extension further indicates aggressive disease and influences adjuvant treatment decisions. So the management of oral mucosal cancer is highly stage dependent and typically requires a multidisciplinary approach. For early stage disease, single modality treatment is often sufficient, and surgery is generally the preferred option here, offering excellent local control and functional outcomes compared to radiotherapy alone in many oral cavity cases. Any surgical intervention typically involves wide local excision with adequate oncological margins, and the extent of surgery varies according to tumour location. So tongue cancers may require partial or even total glossectomy, whilst hard palate tumours may necessitate a maxillectomy. Mandibular involvement may require marginal or segmental mandibulectomy depending on tumour depth and bone invasion. And neck management is a really critical component. Elective or therapeutic neck dissection may be performed when nodal involvement is suspected or when the risk of occult metastasis is high. Sentinel lymph node biopsy is also emerging as a useful approach here in selected cases who have clinically negative neck nodes. In unfortunate cases of advanced stage disease, this often typically requires multimodality treatment, and this may include surgery followed by radiotherapy, with or without chemotherapy or immunotherapy. Platinum-based chemotherapy agents, such as cisplatin or carboplatin, are commonly used in conjunction with radiotherapy rather than as standalone curative therapy. Now, in recent years, immunotherapy has become increasingly incorporated into treatment pathways, particularly for recurrent or metastatic disease. Agents targeting specific tumour receptors, such as epidermal growth factor receptor inhibitors and immune checkpoint inhibitors, now offer us additional therapeutic options, especially in patients who aren't suitable for conventional therapies. Now, I mentioned radiotherapy briefly, and this is a key adjunct in both curative and palliative settings. Now, whilst effective in controlling tumour growth and nodal disease, as we know, it can be associated with significant side effects, and acute mucositis, odinophagia, and nutritional compromise are all common during treatments, and many patients require temporary enteral feeding support, such as a nasogastric or gastrostomy tube. Long-term complications include xerostomia, alterations in taste, fibrosis, and even potential swallowing dysfunction. And these effects can significantly impact on quality of life and should be discussed during any treatment planning. Now, you won't be surprised to know that prognosis is strongly linked to the stage at local diagnosis. Localized disease has relatively favorable outcomes, with significantly higher 5-year survival rates compared to regional or metastatic disease. But once cervical lymph nodes become involved, survival declines, and distant metastasis further worsens prognosis. Recurrence, unfortunately, remains a major challenge, particularly in oral squamous cell carcinoma, and recurrences may occur locally, regionally in lymph nodes, or distantly in organs such as the lungs, liver, or bone, and early recurrence is generally associated with poorer survival outcomes. Now, interestingly, HPV-positive disease, whilst more common in oropharyngeal cancers, tends to have a better prognosis overall when present. Complications can arise from both the progression of the disease and treatment interventions. So surgical risks include wound complications, nerve injury, flap failure, speech impairment, and long-term dependence on tracheostomy or feeding tubes in patients with extensive resections. Chemotherapy and radiotherapy contribute to chronic symptoms such as pain, trismus, xerostomia, and dysphagia, all of which can lead to malnutrition and functional decline. So speech and language therapy, nutritional support, and dental care are all essential components of comprehensive management. Now, beyond physical complications, as we know, the psychological burden of head and neck cancer can be profound. Depression and anxiety are highly prevalent in this patient population and highlights the need for integrated mental health support alongside oncological treatment. So just to summarize here, oral mucosal cancer is a complex and multifactorial disease that requires early recognition, accurate anatomical assessment, and multidisciplinary management. Tobacco and alcohol still remain the dominant risk factors, but as GPs, we must also remain alert to HPV infection, immunosuppression, and regional lifestyle practices such as smokeless tobacco use. And the key takeaway for me is vigilance. Any persistent oral lesion warrants timely investigation, and early biopsy can be life-saving. Comprehensive examination, appropriate imaging, and collaborative care pathways are essential for improving our patient outcomes. So that's a quick overview of oral mucosal cancer, and I do hope you found it helpful. But have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you'd consider following the podcast and leaving us a review on your favourite podcast platform. Do feel free to get in touch via social media at GPnotebook or email us support@GPnotebook.com if you have any questions, comments, or even ideas for future podcasts, as in this case. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups, which occur all year round, and to download free shortcuts to help improve the lives of our patients in primary care. But, as always, until the next time, Thank you for listening, and goodbye.